Great. Excited to get started with our webinar. I'm Lizbeth Otruba. I'm the Chief Clinical Officer for AvaSure. And welcome to our webinar, Reducing Nurse Burnout, Insights from the Impact of Video Monitoring versus In-Person Sitters. I'm really excited about this particular presentation for a couple of reasons. And those reasons are about how this study can be taken and really applied in a broader way. So be listening for these two things. One, I think this is a very important way, an example of how nurses are taking the lead and influencing how technology in virtual care is being implemented. We need to, as a discipline, make sure that we're embracing technology that is a resource gain and kind of rejecting technology that is a resource drain for bedside nurses. And in this next year, we will be continuing to apply the same methodology to further investigate other aspects of virtual nursing models. And then the second thing I'd love you to really listen for during the webinar is how we've taken our two presenters and their team have taken the methodology from another discipline and applied it to nursing research for the first time. So I've always kind of had some issues with the old pre and post nursing survey, maybe months before an intervention, months after an intervention, and as the only way to measure nurses' perception of an intervention. So this is the first time the experience sampling method has been used in nursing to our knowledge. So as you participate, please let your brain think about ways that other virtual nursing models that you think we should study next, and the way you might use the experience sampling method, and we'll also be calling that the daily diary method, to evaluate other things in our fields. So let me just introduce you to our presenters today. First, we have Emily Anderson, MSN RN, and she is a progressive care certified nurse. She received her bachelor's degree from Creighton University and MSN from Liberty University. And she is in Providence, Alaska Medical Center since 2009. So she is calling in with a beautiful background from Alaska, and served in several roles, including charge nurse, assistant nurse manager of the progressive and intermediate care units, nurse manager, as well as interim manager positions for behavioral health and telehealth services. She's rolled out nursing initiatives such as bedside shift report. A lot of us have rolled out that one multiple times myself. COVID-19 surge capacity task force, and the telesitter program there. She was a finalist for Providence Nurse Manager of the Year Award, as well as the March of Dimes Nursing Leadership Award. In 2020, she was awarded the Patriotic Employer Award that was awarded to the employer support of the Guard and Reserve. Emily is an advocate for the nursing profession and a strong believer in nursing involvement at every level of the change management process. In her spare time, she enjoys spending time with her family. We were just talking about trick-or-treating with her family, watching baseball, and enjoying the adventures that Alaska has to offer. And so welcome, Emily. And about a third of the registrants and attendees are nurse managers. So a lot of your tribe is on this call. And then I'd like to also introduce Dr. Don Klumper, who is a professor, and John B. Walker Endowed Professor of Business for the area of management in Rawls College of Business at Texas Tech University. Don has previously been a faculty member at University of Illinois at Chicago, where he was the director of the Institute for Leadership Excellence and Development. It's this interesting career path. He received his PhD in management in 2006 after a career as the director of human resources at a large employee nonprofit organization. So his research interests center around personality in organizations, workplace mistreatment, leadership, and research methods. So this is very applicable to the nursing profession. Don has been widely published in both professional journals and now in a nursing journal and media outlets. He's taught courses at undergraduate, master's, and PhD levels and has won various teaching awards, which is not surprising to me because over the years that we've collaborated, he has certainly taught me a lot. So I'm going to hand it over to you two, and we're really excited to hear about this research that you conducted and then did publish on.
Thanks, Elizabeth, so much for the introductions. So if you can move to the next slide. So I do want to mention the other members of this global research team. So the project started really at the University of Illinois Chicago when I was employed there. Sandy Wayne is a faculty member there who is now the Dean of the College of Business at the University of Illinois Chicago. And Jaiking Kathy Sun was a PhD student there that is now gainfully employed at the London School of Economics. So in evolving and moving through this project, we realized we needed to have nurses to give us some important context. So Emily Anderson, who was just introduced, and Crystal Billings, who's at Providence in Olympia, Washington, were added to the research team to give us more insight into the day-to-day workings of nurses. We brought in Chris Rosen, the author at the bottom, because he's an expert in the conservation of resource theory that we used in this model. And then Joel Koopman and Young Lee was his PhD student at Texas A&M, were brought in because they're top experts in the world on the experience sampling methodology or daily diary design that we're using. So we brought them on board because we're dealing with very complex analyses and a very rigorous approach. So that's the full research team.
Okay, great. I'm going to get us started. And just to get started here this morning, thank you all for taking the time to be here. We're really excited to be able to present this webinar with you all. I'm going to start off with a quick little poll. So if we can launch that real quick, we are going to love to see what level of engagement you guys are at with virtual sitting or virtual nursing, if you've done any of it within your organization or both. So I'm going to kind of let that sit for a moment, see. Awesome. So it looks like we've got a crowd that definitely has dove headfirst into the virtual world a little bit and how telehealth can help augment what we do at the bedside. So great. Okay, well, I'll tell you a little bit about the setting, at least up here at Providence Alaska Medical Center. We're a 401 bed facility, and we launched our video monitoring technology program in fall of 2017. And it started pretty small with just a couple units and has grown ever since. It's become a really important part of what we do. We've involved it in many different policies, many different procedures, and how we safely take care of our patients, but also ensure we have good resources for the caregivers at the bedside. So up here in Alaska, we're based out of Anchorage. We have 3 critical access hospitals in Kodiak, Seward, and Valdez. And then we have a specialty facility also here in Anchorage and a long-term nursing facility. So PAMC monitors, does have video monitoring technology beds at all of those locations. So what we're able to do from a larger site here in Anchorage is able to help support some of the needs within our very small critical access facilities where resources can be even more tight, kind of harder to recruit to areas, but communities that really, really need to have those services in place within their locations. So next slide, please. Anyone that's worked in an environment in healthcare knows exactly what an in-person sitter can do to the unit. There are definitely effects. Some are positive. You have a person that's there taking really good care of that one patient, but many of the effects are often taxing to the staff and to things like our productivity. So, if you have an in-person sitter, that extra caregiver on the unit is often only taking care of that one single patient versus taking a normal patient assignment which can often lead to increased assignments for those left on the floor to cover the unit. At some locations, I think you're able to add an additional body, which does then negatively impact your unit productivity because you just have that one person taking care of one patient versus kind of spread out to even the workload amongst the rest of the team. But up here in Alaska, we would often need to pull from our floor staff for our one-to-one usage before asking for additional support from the house supervisors. So what that means for the team, then you lose that person off the floor, which reduces the coverage for answering call lights, bed alarms, doing those really important interventions with our patients to keep them safe and healthy, like walks and baths and oral care and safety rounds. Although staff still also do need to do that, so it increases their tasks that are placed on them for those that are left to do the work, which kind of really amplifies the resource loss with an in-person sitter use. Additionally, I kind of mentioned it already, but unit productivity is probably on everybody's radar. Try to hold our finances really close and really tight. And so anything additional that you do not budget for or plan for often takes a negative impact on that for the unit and the larger organization. Next slide, please. Some additional effects when what that resource loss feels like is the reduced ability for the staff to take appropriate breaks and meal periods. We often see an increase in how many of our nurses and techs really clock out as no lunch. They appear to be more visually stressed, frustrated. There's lots of negativity sometimes around feeling short-staffed, even though you were probably most likely staffed to begin with, but in order to make that assignment happen, you had to pull someone from the floor. So it does leave that feeling that you are short. And really, it just increases the stress on the team from providing what we feel in Alaska is really an ideal team-based approach to providing patient care to more of a primary care model that is harder to achieve and is harder to do at an increased ratio. Next slide.
All right, so I'm a methodologist and a statistician, so I'm going to talk about the nerdy part. So we started this study. We ended up doing three studies, and all of them were approved by our institutional review boards. Next slide, please. So in the first study, this was a qualitative study where we had roughly 45-minute interviews with so we had 5 nurses that were dealing with video monitoring technology and in-person sitters. We had 2 nursing campus coordinators and 2 monitor techs that we interviewed, transcribed those interviews to give us a much better insight and understanding into the kind of research model, the design for the study that we wanted to pursue. All of the participants in that study received $50 for participation in that first wave of the study. Next slide, please. So once we decided what we wanted to study as far as the research model that I'll go into next, we wanted to validate all of the measures that we were using. So we ran a validation study, collected data from 40 nurses, about a 20-minute survey. We paid them $30 each. And from that, we made improvements and verified that all of the measures that we were going to be using in the main study were psychometrically sound. Next slide, please. So in the next study, the main study, this is that experience sampling or daily diary research design that Elizabeth was talking about earlier. So we ended up having 100 participants total, 100 nurses. 74 of them completed all of the surveys, and some of them didn't complete all of the surveys. So this type of design has some unique aspects to them. So firstly, there's a baseline survey of things that are measured one time. Then there are 2 surveys every day when a nurse is on shift that they will complete for every day they work on shift for 3 weeks. So we're getting multiple reports from nurses for multiple days and multiple times in each day. And what that has the benefit of doing from a methodological standpoint is we're able to control the prior time period, and we're able to do something, the effect of do things that happen in the morning affect things that happen in the afternoon. So aside from the randomized control group kind of design that is best practice to determine causality, which would be impossible to do in this type of a context, this would be a very strong research design that has very strong causal implications. So we paid these nurses anywhere between $70 and $102 because it's very labor intensive. The totality of the surveys over the course of 3 weeks was 2 hours in length. So next slide, please. So the measures that we're using, so the primary measures when we talk about resource gain and resource loss, is that when an in-person sitter is used, often, as Emily was talking about earlier, those resources are taken away from the team, from the nurses, to sit and watch one patient. So we assessed the number of in-person sitters that are used for a particular nurse, and then we also measured how many video monitoring technology, how many of their patients had video monitoring technology, and we theorized that as a resource gain. In other words, there's somebody else that's watching and helping with that patient that doesn't take resources away from the nurses, and that's going to hopefully benefit nurses. So in the one-time survey that we did, the baseline survey that I talked about in the last slide, we also measured a construct called nurse commitment that you see it becomes relevant as we get through the hypotheses. So essentially, this is a 4-item established measure. Sample item is I get a great deal of satisfaction and fulfillment for being a nurse. So we measured nurse commitment. Next slide, please. So this construct hasn't been studied all that much in the nursing literature, but I think you'll find that it's quite relevant. So in 1983, Hochschild wrote a book called A Managed Heart, where she explores this concept called emotional labor. So essentially, we all have genuine emotions, but sometimes the situation dictates that we need to act differently than we feel, right? So there are a couple of different dimensions. So there is deep acting, and this would be a situation where somebody can sort of get in the mindset of being, let's say, positive if they need to be positive. So a customer service representative, for example, might get in a positive mindset, and then they're always smiling. Now, for nurses, that's going to be challenging because if you get yourself in a positive mindset, you might need to go from one room where you need to be, happy for someone, in another room where it's a very sad kind of environment, and your emotions would fluctuate quite a bit. So the deep acting is very challenging. So what we're focusing on is the other dimension of emotional labor called surface acting. Essentially, surface acting is just faking it. So you feel a certain way, and you're going to act like you're engaging in an emotion that you don't really feel. So this surface acting is tied to a concept called emotional dissonance. So the fact that you have to act and engage in an emotion that you don't really feel is really a stressful kind of a situation. And the more you have to act, the harder that is, the more draining it is. So can we go ahead and run the poll? So got a question. So we're curious how often you engage in surface acting in your roles.
So, Don, this is Elizabeth. I'm just popping in because we've just got a really interesting range of nurses that registered from this webinar. So 30% I mentioned nurse managers, and then we have about 23% are nursing directors and about 10% like chief nurse level, and some bedside nurses as well. So yeah, we all thought this when we were prepping for this webinar that this probably applies to all of us. So great. I'm going to close that poll.
Yeah, fantastic. So everybody was at least sometimes or frequently. So it's something that nurses are doing. All nurses really are doing to some level. So next slide, please. So the emotional dissonance that comes along with having to engage in that surface acting, we're going to be arguing in the hypotheses that that's going to lead to higher levels of burnout in nurses. So burnout's been studied quite a bit in the nursing literature. It has 3 dimensions. The most studied dimension of burnout is emotional exhaustion. We're looking at it from a bit of a more malleable. So daily emotional exhaustion over time would lead to a chronic burnout that then is tied to a lot of different kinds of outcomes, like lower work performance, poor mental health, poor physical health, poor personal relationships. And this was also tied to higher levels of turnover of nurses in hospitals. So this is one main contributor to that. Next slide, please. So in our hypotheses, we're arguing at the front end of the model essentially that the resource loss from having an in-person sitter that is taken away from the nurses is going to have an impact on their surface acting, and that the resource gain from having the video monitoring technology is going to have a positive impact on that. But we also look at nurse commitment here as a moderating variable. So the relationship really depends on nursing commitment. So to go into a little bit more detail about that, if a nurse is very committed and engaged in what's going on in their environment, they're going to have to fake less. They're more likely to have and be closer to the genuine emotion. So if they walk into a room and it's a really sad environment, they're more likely to feel sad, and therefore they're less likely to have to fake it as much. So what we're arguing here is that the nurses that have lower levels of commitment are going to end up having to fake more, and that's going to have more of a resource drain on them when the in-person sitter is used, or it's going to help them more because they don't have to fake it as much when there's a resource gain. So in our hypotheses, we find that these were supported. The first one was supported, and the second one's partially supported. So we'll go to the next slide. So we look at this interaction plot. So first, the first thing I want to point you to is the line at the bottom are your highly committed nurses. And you'll see that your highly committed nurses are engaging in lower levels of surface acting. So that black line is below the dotted line. So the dotted line are the nurses that are lower on commitment. So our argument for our theorizing was that the nurses that are less committed are going to need to fake more, and that's what we see with those mean differences of the dotted line being higher than the solid line. But then if we look at the dotted line, the direction that it's moving, so it's tilting upward at the top, and it's tilting downward at the bottom. And how we interpret those results is that the more a nurse that is low in commitment uses an in-person sitter that takes away their resources, that is a resource drain, that leads to more of that surface acting and more of that emotional dissonance. And when the less committed nurse has the resource benefit of having the video monitor technology, their need to surface act decreases. So the bottom The bottom graph there is showing that dotted line is decreasing as they get more resources of the video monitoring technology. So those two hypotheses were supported. Next slide, please. So then we take surface acting and link it to emotional exhaustion. So essentially we take that emotional dissonance part of having to fake it and the stress involved with having to fake it and say that's going to lead to nurses being more exhausted. And we find that that's supported in the literature. And then we put all of these together and we look at what's called a moderated mediated model. If you'll please move to the next slide. So this looks at everything all at once. So we have the in-person center use and the use of video monitoring technology, our resource gain and a resource loss. We'll see that those do lead to surface acting that is moderated by, that is impacted by the level of commitment of the nurses. So the effect is really for the nurses that are lower in commitment. That's going to affect their levels of emotional exhaustion or burnout. And so we see these what are called conditional indirect effects that are significant for both of those paths. So what this essentially means is that the nurses with lower commitment are likely the ones that are more likely to leave anyway. And this is going to accelerate that process because they're the ones that are going to have more of the burnout because of the emotional labor that they have to exhibit. Next slide, please.
Great. Right back to me. Don, you do a great job of explaining that. I feel like I learned something new from you every time you go through it. So thank you. So kind of tying it back all together in with the research and then the utilization. So currently, the opportunities for video monitoring technology are kind of endless. And so currently within the Alaska world up here, we utilize it a lot. So most commonly, of course, like our risk to fall patients and our preventing of pulling lines and tubes, right? Those things that we can do really rapid redirection to patients and help save them while we're kind of keeping that resource within the unit to be more accessible to all the patients involved. We also use it pretty frequently for our confused and demented patients. Sometimes redirection can get harder with those patients, but we work really closely with the bedside staff on when to use stat alarm, when to redirect, when to try to call, really to fit the need of what the bedside team needs to take care of their patients safely and really keep the patient safe. We also use it to monitor patients at risk for using their IV lines for drug injection. We've used it for elopement risks and wandering patients where we will position the camera in the hallway and be able to monitor when a patient may leave their room or a specific area that they're supposed to remain within. We also we have utilized it for high-risk patients and keeping them safe from their own visitors. We recently had a situation come up where they were able to capture a family member taking the patient's phone and attempting to withdraw money and do things on the phone where we were warned to kind of monitor that patient for safety. Drug and alcohol withdrawal, we utilize it very frequently for that. Eating disorders, and then we utilize it for low-risk suicide patients in our emergency department. This is really important to us, especially coming into the winter. Alaska gets cold and chilly and dark, and we have a pretty large homeless population. So there is a large population of patients that know that if they come into the emergency department and say very key things about suicide ideation, it will allow them a warm, safe space for a really cold night. So by being able to assess them with a provider, we're able to at least monitor them for safety with the video monitoring technology to really ensure they have met their safety before discharging them back to their environment. And then the last one I wanted to call out is we have used it quite a bit to improve our caregiver safety within patient populations that are flagged at high risk for violence. And this could be young elderly, really anyone that we've had either verbal or physical flags of violence with these patients. So we utilize a camera in the room. So you're almost able to provide cares in pairs without necessarily having another physical person with you in the room. So I'm going to launch the last poll question that we have on that, because I really think, right, caregiver safety is always at the forefront of a manager, a director, CNO, and the caregiver, bedside caregiver's mind. But how comfortable are you currently with your policies regarding sitter usage on potentially violent patients? And if that's you are satisfied or not. I'll kind of share one thing while we look at these poll results, is that up here at Providence, Alaska, we actually have it within policy that if we have a patient flagged at risk for violence, we do put a video monitoring technology in the room to help keep caregivers safe. So it's really to help minimize putting a one-to-one in that room where we know we are at higher risk for something really bad to happen or really unfortunate to happen. We don't even put the caregivers in that place. So it looked like a pretty good mix there of people that think that there's some work that can be done, that are happy, and then just not sure. So I do recommend thinking of ways to use the video monitoring technology for caregiver safety. I think initially we think about our patients, but this is a really nice way to also help keep our caregivers safe in these kind of patient situations where you could remove a caregiver from an environment that could be unsafe for them and monitor them with video technology. So next slide, please. So last little bit, kind of discussing, really kind of closing it out for us before we hit the Q&A. But really, when nurses appropriately use video monitoring technology, we really find that we can retain our techs on the floor and maintain their normal ratios for consistent patient care. We do have standards that we ask the charge nurses to require trialing video monitoring technology for anyone that's not within a diagnosis that would need a one-to-one per policy, such as full face BiPAP or suicide ideation on the floors anyways. Most of this actually helps find that this technology can be useful. We do have them trial it before we put the one-to-one in the room to just minimize the resource loss. And we find about 80% of the time the patient can be very successfully taken care of with the video monitoring technology than pulling someone from the floor. Additionally, we've seen a reduction in falls with injury with utilizing video monitoring instead of just one-to-ones, because it does still allow normal ratios out on the floor. They're available for call lights, bed alarms, and our video monitoring techs really can monitor them well, stat alarm them when we need to get into the room, and help redirect before the patient even gets out of bed. Next slide, please. And then with our nurses up here, they are part of a union contract. And so we do track their breaks and their meals very closely. And we do see a correlation that when we have to pull techs from the floor, that the nurses often don't have the ability to take their full meal breaks and rest periods when they are working with less techs on the floor. And we are able to track this because it's required by the union contract, but it's another way for us to really kind of tie the whole picture together, that we need to utilize the video monitoring because this is important for caregiver health and their own kind of personal well-being too. And of course, we'll close it out with the financial benefit. Really, it's a decrease in the incremental overtime that we see, but it also allows staff to go home. All of our caregivers at the bedside work 12-hour shifts, and that's a long time to work with people on your feet and doing tasks. So the sooner they can go home, the better. I think that kind of closes it out for our presentation today. Open it up to Elizabeth here.
Awesome. Yeah, there are a few questions. And feel free, those who are attending, to put questions in the chat, but one of them is there seemed to be a difference in the low commitment nurses versus the high commitment nurses. And I don't know if you can answer this, Emily, or if you have a sense, those kind of low commitment nurses are those that are those the nurses that might be at risk for leaving your organization? And if so, do you have the sense, are they more novice nurses or more senior? Or was it not anonymized and you have no idea?
Yeah, I mean, from the study, we wouldn't have an idea from that, but I can kind of speculate that yes, that those would be the more at risk to leave, and probably sooner if resource loss is a big issue within their, their work day. What we find here within Alaska right now is I do feel like those are more the novice nurses. We find a lot more commitment to our longer term or nurses who have been here greater than 8, 9, 10 years. They seem to be a little bit more set into the environment. They've been through a few different changes. They've, and maybe even like the pre-pandemic nurses have the kind of ability. They've worked through a lot of different stuff. So um, I would say that probably affects our newer novice nurses more.
Yeah, I was wondering, but it could be different in different areas of the country.
Yeah.
And I got the workplace violence was a really fascinating topic. I just got back from the Magnet conference, and I am a recovering Magnet program director. So I I had to attend one of those sessions just for nostalgia, and they're really, really focused on and increasing kind of the threshold for what needs to be reported on workplace violence. And so
Mhm.
virtual monitoring for staff safety is another way to meet magnet criteria. And we got a question about this from Joe Cowan, who happens to be one of our AVA Prize recipients at Ascension. So hi, Joe, great that you're participating. And he was wondering about what percentage of patients or how many patients are monitored for workplace violence.
Yeah, that's a good question. So I'm just trying to think within kind of the last couple of months. So we have the capability to monitor a total of 36 patients at a time, so 3 different workstations. And our average daily census runs about 30 or so. I would say that maybe four to five of those are monitored for workplace violence. There's you're monitoring them for that, but there's probably also criteria that we are classifying them as also they tend to be confused or agitated.
Yeah,
So are they getting out of bed, right? Because they're high risk to fall. But we do try to prioritize like what we're watching for. And I would say, yeah, maybe 20% of them sometimes. Yeah.
yeah. It's sometimes hard to predict who is going to be violent.
Yeah.
But another session that I went to, and I asked for the reference from the speaker, and I'll let you know when she gives me the reference. But she was saying that sitters are some of the most at risk for violence in healthcare. So healthcare workers are 4 times more likely to experience violence in the workplace. And then of healthcare workers, sitters are like some of the top to experience violence as well. And that makes sense. I mean,
Yes.
it's very agitating to have someone kind of sit and stare at you 24/7 when you're already confused and agitated and have a lot going on. So,
Well, I think there's kind of this feeling that if you're there, you're supposed to keep them safe no matter what. And we
mhm.
often then put aside our own personal safety in those situations because you may get pinned in a section of the room that you don't have a good escape route, or the patient is pulling at stuff or doing something. You do try to get closer to them and you forget, keeping your safe distance, and you feel like I'm here to do this with this one patient. I must keep this patient safe. I must stop them from doing this. where I think it's probably easier to forget about being safe in those situations, because this is my job today. I am here to keep this patient safe and have them stop doing that. Um, and they will do that to the end. But yes, we have really unfortunate situations. We've had people get punched.
Yeah.
We've had broken noses. We have people, touched inappropriately. It's just endless, right? So we've really also encouraged like we have a lower threshold of reporting those events, because we want to know, we want to be able to do something about it. And the only way we can do something about it is we know really an accurate amount of how many times it's occurring.
Yeah, that's a tough thing too, because people think
Yeah.
it's just my job. And then another AVA Prize winner is asking another question, and this is from Sharia Maltry from the VA, Veterans Administration, and thank you for what you do to keep our veterans safe. So she's asking, for violent patients, how often do you have equipment loss or damage during an incident?
It's become a little bit more rare, but I mean, it's not uncommon. We try to have a lower threshold for security intervention too, and I think with the video monitoring technology, it's something in the room to remind staff that this patient's being monitored. Our monitor techs can call security directly also if they see something escalating in the room. It's fairly rare, but we've had computers ripped off the wall, Philips monitors, cardiac monitors thrown across the room. But we do, if someone's going to be really agitated, we do try to prep the room as best we can to
Yeah.
remove anything that could be used as a weapon. But again, I think that really highlights the more benefit to using video monitoring technology in those rooms that a caregiver, if you have to have someone in there, they're not in there alone. And
Actually,
we do staff
her question was
security
about,
too.
yeah, and I think that's phenomenal. Monitoring staff should be empowered to call security the same way as telemetry techs can call a code if they've checked,
Correct.
BFib and a couple different leads.
Yeah.
But her question was, how often do the cameras get damaged?
Oh, sorry.
I didn't
Um,
make it clear. I'm sorry.
Very
There's all
rare.
kinds of
Yeah.
equipment in the room that could get damaged. Yeah.
Yeah, no, very rare.
Okay.
I can't think of anything within this year at all that we've had the cameras damaged.
Okay.
I
So I
think we
think
have all the mobile cameras too, so they
it's
can be
mobile.
easily
Okay.
moved out of the way, right?
Yeah.
So yeah, no, I can't think of any events this year where that's been damaged.
Okay. So, because I think that's a fear, but maybe not a reality. And we have I'm at our manufacturing campus right now, and so sometimes I walk back where we do camera replacements, and I ask the guys back there, I'm like, have we gotten any cameras returned because the patient's damaged? And it's pretty rare. It's pretty rare here too. So that it's good that you're seeing that on your end as well, because
Yeah.
you're saying 20% of your is
Hmm.
violent. You use mobile devices, so they're not in the
Yep.
ceiling, and you're
Correct.
really not seeing that happen. So
Yeah.
okay.
Hmm.
Um, Maybe one more question. Have I missed? I've got my sidekick in the room with me. Have we missed any other questions?
No,
I I had just one more question on the daily diary kind of format, and I imagine, Emily, that you do other kinds of nurse satisfaction surveys. I know you have a magnet hospital, so you have to do. How would you compare and contrast this type of survey to the other types of nurse satisfaction surveys that you do? And you
Yeah,
work with
I
this daily diary.
I liked it. I think it was very different. The daily diary approach, very different to what we're used to in healthcare, because we're either used to a single once a year type nursing satisfaction or caregiver satisfaction survey. Up here, we've actually shifted our caregiver engagement surveys to be quarterly, which I actually have found a lot of benefit in. But I think there's a lot of intrigue in this daily approach too. Although for sustainability, right, it's has to be for specific things. But no, I think that it's interesting, and yeah,
Yeah, I mean, it's a little more labor intensive, and
yeah,
this one, AvaSure funded the gift certificate card, gift cards for them to, because they had to take time out several times a day for 2 weeks, and so through
yeah.
the
And I
IRB
would,
approval process, and yeah,
and I think
okay.
from Don's team, he probably has feedback from the just then the taking all of that and looking at it together. It's a lot of entries. It was a lot of labor intensive time doing
It's
that
a lot
too.
of data. I mean, I guess just to point out some of the highlights of the method. So it's a really good way to look at what happens within a day. So we talk about like a pre-post testing with long time lags. You really don't have the ability to know like what's happening within a day. So one way of thinking about this daily diary approach is that we have sort of this pre-post every day. As conditions
Yeah,
change and there's like
yeah,
more video monitors used or more in-person sitters used, you get to see how that person sort of responds differently to different resources that they have. And then again, as I said earlier, we are allowed to we in this with this methodology, we're allowed to control for the prior time period. So instead of just like in a score, assessing a score, it's that score with the prior score subtracted from it. So we see a change in service acting, a change in burnout. So we could directly tie
yeah.
daily fluctuations, the daily changes in those outcome variables, which is much more dynamic, accurate, better causal inferences. Again, that's much shorter time frame to look at the daily perspective.
Mhm.
Right, because even if you're doing it once a quarter, there's a lot that
Yeah,
you're trying to do to improve your staff experience in a quarter, and you can't pinpoint that this thing is necessarily cause this outcome. So I think I'm going to finish with this last question. It's really some good questions. And this is from Brandy Slade from Overlake Hospital. How many patients do each of your techs monitor, and do you have an acuity system to kind of even out the busyness of those three stations that you have?
yeah. So at the time of this study, because we've transitioned to like a direct co-care model in the last month or two, but our techs were taking 9 to 12 patients apiece. So they would take 9 patients on day shift and 12 on night shift.
Oh,
As far as acuity tools, we don't do that. We don't utilize one other than kind of the feel, the feel for how each patient assignment is. And we've recently had the charge nurses making assignments based on workload, but we don't use Epic for like a actual, there are acuity tools out there that we could use, but they don't use that. They just kind of see how the acuity feels on the unit. But
for
they,
the sitter patients, I know that there is a dashboard where you can see how many verbal interventions each patient has had, how many alarms they've had. So there's the ability to kind of use data to
yeah,
shift patients around. I know, alcohol withdrawal patients tend to be busier.
yeah.
And so I don't know, were you
Our
thinking of bedside
Our
or
video, yep. So our video monitor techs take up to 12 patients,
up to
and
12?
they
Okay.
will shift patients depending on acuity for verbal interventions or stat alarms. We do
Okay.
find that sometimes we have to do it multiple times within a shift too,
Yeah.
depending on new admissions or um, you know patients that might, if they're medicated or as bedside interventions
Mhm.
improve them, their redirections and stat alarm usage may go down, where another one is kind of escalating from a new admission. So they do multiple kind of changes. But yeah, between 12 and 10 to 12 patients they monitor every shift. Yeah.
Okay. Okay. This has been awesome. Thank you both. And I think we put your article. So if anybody wants to pass that on to their nurse scientist or clinical nurse specialist or something, that's in the chat as well as oh, and we just wanted to give a plug for our upcoming webinars. coming up what's new with AvaSure on November 20th, because I know some organizations have been with us so long they don't know about what's been new with us. And then the AvaSure maturity model, I'm going to be presenting alongside with Claire Zangerly, kind of about how to move in from just first initially starting inpatient virtual care into the future of nursing, and how nurses need to and can take the lead on that. And then this last slide here is how you can, we're able to provide one contact hour for attending live today. So if you complete an evaluation and register, this has been co-provided with AvaSure, and St. Anselm College is approved as a provider of this nursing continuing professional education. And I'm going to make sure I'm saying this correctly, that this was, jointly provided, and all relevant financial relationships have been mitigated. So you can either use the URL code, QR code, or use the link in the chat. Okay, great. I want to just make sure everybody has a chance to grab those. So thank you again, Emily and Don. Looking forward to what research is coming out next. And those of you who have participated today, if you're thinking that you would love to kind of use the same methodology or a similar one to continue to look into like virtual nursing, maybe is virtual nursing admissions or virtual nursing discharges or quality audits from a virtual nurse, how is that perceived as a resource gain or a resource drain? How does it impact the emotional work of bedside nurses? I think these are questions that we must answer. So please let us know if you are interested in exploring those questions with us. And thank you all for